Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jacqueline Meredith. In today's episode, Dr. Christopher Bowlus from the University of California, Davis School of Medicine discusses recent advances in the management of PBC. In this episode, we focus on new FDA approvals. This episode is part of a larger educational program titled Keeping Up with New Developments in PBC. For more information on Dr. Bowlus, along with a link to the larger educational program, please visit the link in the show notes. Now let's get started and hear what he has to say about this important topic.
Let's look at the PBC treatment goals. There are two main goals to the treatment of PBC. First, we want to prevent the development of clinical outcomes. These include cirrhosis, hepatic decompensation, such as ascites, variceal bleeding, and hepatic encephalopathy, and ultimately liver transplantation and liver-related death. At the same time, many of our patients suffer from debilitating symptoms, most notably itching or pruritus and fatigue. And a significant part of our treatment goal should be to alleviate these symptoms. There are three important aspects to how we define a biochemical response in patients with PBC treated with ursodeoxycholic acid. This largely comes from an analysis of nearly 5,000 patients from 15 sites in North America and Europe. In this study, there was a clear linear relationship between the level of alkaline phosphatase after treatment and the risk of liver transplantation or death. A threshold of 1.67 times the upper limit of normal has been established as a cutoff to define a complete biochemical response and has been used in clinical trials. Importantly, the reduction in alkaline phosphatase from baseline is also significant in terms of understanding the reduction in the risk of liver transplantation or death with treatment, even if a biochemical response is not achieved. That is, the further we can reduce the alkaline phosphatase, even if we don't achieve normalization, is important for our patients. Recently, there have been new targets for the treatment of PBC. The mechanisms of action are all targeting the bile acids produced in the liver. Ursodeoxycholic acid is in fact a bile acid and works by changing the bile acid pool so that the more toxic hydrophobic bile acids are diluted and cause less cellular damage. Obeticholic acid is a farnesoid X receptor that reduces bile acid synthesis and intrahepatic circulation of bile acids. And more recently, PPAR agonists have been developed which reduce bile acid synthesis through a mechanism separate from the FXR pathway. Recently, two PPAR agonists have been approved for therapy for the use in PBC. These include seladelpar and elafibranor. Seladelpar was approved in August of 2024 and can be used in combination with ursodeoxycholic acid or as monotherapy in individuals who are unable to tolerate ursodeoxycholic acid. Similarly, elafibranor was approved in June of 2024 and has similar indications. Bezafibrate is currently being developed in combination with obeticholic acid. Bezafibrate received orphan drug designation May 2023 and is being studied in a fixed-dose combination. Notably, obeticholic acid, an FXR agonist, has previously been approved for therapy as monotherapy or combined with ursodeoxycholic acid since May of 2016. Now, PPAR agonists come in many different types and have different specificity to the three different types of receptors that make up the PPAR family. Notably, seladelpar is the delta-specific PPAR agonist. Elafibranor has both alpha and delta PPAR activity, and bezafibrate has pan-PPAR activity against all three isoforms of the receptor. Seladelpar was studied in two phase 3 studies, the RESPONSE and ENHANCE trials, elafibranor in the phase 3 ELATIVE trial, and bezafibrate in the phase 3 BEZURSO trial. In the ELATIVE trial, this was a randomized, double-blind, placebo-controlled phase 3 trial of patients who had an inadequate response to or had a history of intolerance to ursodeoxycholic acid. After 52 weeks, patients treated with elafibranor had a response rate of 51% compared to 4% in patients treated with placebo. In addition, 15% of patients treated with elafibranor had a complete normalization of their alkaline phosphatase at the end of 52 weeks. There were also signs that elafibranor had improvements in itching in patients that came into the study with moderate to severe itch. The main measure of itch in this study was the numeric rating scale. While this did not reach statistical significance, there was a numerical improvement in the score, and other measures of itch did show signs of improvement. The RESPONSE trial was a randomized, double-blind, placebo-controlled phase 3 trial of seladelpar in people with PBC who had an inadequate response or were intolerant to ursodeoxycholic acid. In this study, 61.7% of patients treated with elafibranor had a biochemical response at 52 weeks compared to 20% treated with placebo. In addition, 25% of patients treated with seladelpar achieved normalization of their alkaline phosphatase compared to none treated with placebo. Among patients with moderate to severe itch in the RESPONSE trial, there was a significant improvement in pruritus measured by the NRS score among patients treated with seladelpar compared to placebo. This was also seen in other measures of itch. The third PPAR agonist to examine is bezafibrate, which was studied in a randomized, double-blind, placebo-controlled phase 3 trial in patients with PBC who had an inadequate response to ursodeoxycholic acid, but here they are based according to PARS 2 criteria, which are different from the other studies. In addition, the primary endpoint was a complete response defined as normalization of total bilirubin, alkaline phosphatase, aminotransferases, albumin, and prothrombin index at 24 months. The complete response in this context was achieved by 31% of patients treated with bezafibrate compared to none treated with placebo. There was also a tendency towards improvement in pruritus among all patients treated in this trial with bezafibrate. Finally, there are phase 2 trial data using a combination of bezafibrate and obeticholic acid in a similar group of patients with PBC who have had an inadequate response to ursodeoxycholic acid. What is most notable about this trial is that the combination of bezafibrate at 400 milligrams and obeticholic acid at 10 milligrams achieved up to 65% reduction in alkaline phosphatase from baseline, which is much greater than we've seen in the other trials, which tend to have approximately a 40 to 45% reduction in alkaline phosphatase. This then gets us into the maximum effect we could see with reduction in alkaline phosphatase based on previous studies of patients with PBC. So our key take-home points are that PBC treatment goals include preventing poor clinical outcomes and improving quality of life. Patients that do not achieve an alkaline phosphatase less than 200, or about 1.67 times the upper limit of normal, should be considered for a second-line agent, and this includes seladelpar, elafibranor, or obeticholic acid. And finally, in patients with itch and an elevated alkaline phosphatase, PPAR agonists have been shown to improve this symptom.
Thank you, Dr. Bowlus, and many thanks to our listeners for joining in. As a reminder, to view the full program, Keeping Up with New Developments in PBC, please click on the link in the show notes. And to get access to all our new podcasts, subscribe to the CCO Infectious Disease Podcast on Apple Podcasts, Google Podcasts, or Spotify. Thank you, and have a great day.